Good afternoon. This chapter, well, if I can keep my camera from sliding. Let's see, that looks okay. All right. So this chapter is on a team approach to healthcare. It is going to have some related videos for you to watch that will be external. So just be aware of that. So regardless of your level of training, just because you're an EMT does not mean you're not a critical member of the healthcare team. A paramedic needs a good EMT to be able to help them carry out patient care. So you are just as critical to that patient and their outcomes as the paramedic is. So by working in a team, an emergency healthcare provider can actually improve patient care and provider safety and deliver better emergency care. So regardless of your training level, you are still very important to the team, and never underestimate that. Doesn't matter what that other person says, they need you in order to function properly. So there is a level of community care or healthcare that is changing and developing, and it's something that's in its infancy stage here in West Virginia, and it's called the community paramedicine and the mobile integrated healthcare system. And these teams may be the best examples of the team concept of continuum of care. And essentially what has happened is nationally any of these hospitals that obtain federal funds for their patients or receive federal funding at all are required to report patient care outcomes. When they do, if a patient is discharged from the hospital after being seen for congestive heart failure, and that patient readmits to the hospital within 30 days of the date that they were in originally, the hospital is fined some of that money and they're required to pay back any federal funds that they received. So there is a big push by the hospitals to make sure that there is a continuum of care that exists beyond that of the hospital setting. So they are looking at the responsibility they have to keep these patients from readmitting into the hospital. And in order to do that, they've created a system called community paramedicine and the mobile integrated healthcare system, in which EMS personnel are trained to an additional level and then required to go into the houses of these individuals and provide these different needs to assess the patient and make sure that they are staying well enough to be handled outside the hospital setting. And it's kind of as an addition to healthcare nurses and the in-home healthcare system. So we are kind of a part of that. The structure and effectiveness of the emergency healthcare team does differ from one system to the next. And like I said, West Virginia is still in its infancy. There is some pilot programs going on in the state, but they are still looking at reimbursement schedules. So because of that, it's not become upfront and in our face all the time. So there are different types of teams. There's a regular team where the EMT is consistently interacting with the same partner or the same team every day. And then there's temporary teams where the EMT works with providers with whom they do not regularly interact or may not even know. And this happens regardless of where you work. Those temporary teams do exist, and it is a commonplace occurrence. Now, there are specialized teams that are out there, such as fire and rescue, hazmat teams, tactical EMS, special event EMS, EMS bike teams, in-hospital patient care technicians, and again, those mobile integrated healthcare techs. So a group versus team. A group consists of individual healthcare providers that are working independently to help the patient. This may be triage, treatment, and transport. A team, however, consists of a group of healthcare providers who are assigned specific roles and are working interdependently in a coordinated manner under a designated leader. So there are 5 essential elements of a group. And those are: 1, the group has to have a common goal. Two, that group and those individuals within the group have to have an image of themselves as a team. So it has to be a group thought and a sense of continuity among the group. This is a shared set of values, and there are different roles within the group. Now, there are things called dependent, independent, and interdependent groups. Now, your dependent group is each individual is told what to do and how often to do it, and it's by his or her supervisor or group leader. Whereas an independent group, each individual is responsible for his or her own area. And then healthcare providers who work interdependently are functioning as a true team. Effective team performance means that there has to be that shared goal with clear roles and responsibilities among its members, diverse and competent skill sets, so everybody has to know their job, know what they can do, and know what they can't. There's an effective collaboration and communication, and then supportive and coordinated leadership. Communication and team dynamics is fostered from crew resource management and team situational awareness. And crew resource management recommends the use of PACE. This is referred to as probe, alert, challenge, and emergency. And transfers introduce the possibility of patient care errors. So whenever we go into a transfer setting where we're providing care that's getting switched over, maybe it's the EMT that originally got to the call and then you're turning that care over to the paramedic that comes on the scene, that transfer of patient care can cause errors to occur. So we want to make sure that we create a nice smooth transfer, and these are the guidelines that we generally want to follow. So there needs to be an uninterrupted critical care, minimal interference with respectful interactions between crew members, using common priorities and common languages. And that's become very important ever since 9/11, is that there is a use of common languages and systems in place that providers from different levels, different agencies, everybody understands what's expected. So BLS and ALS providers working together, care cannot exist without each other, and that's something that I mentioned at the beginning of the lecture. Your BLS efforts have to continue throughout the continuum of care. It doesn't matter what that ALS provider can do. If there's not a good solid BLS to maintain the airway, the breathing, and the circulation, then nothing that paramedic does is going to matter. So what may be paramedic only skill in your EMS system may actually be common for an EMT to perform in another. This is really important in West Virginia. A good example is the King Airway. You will see in the textbook here and in this chapter that the King Airway is actually considered an advanced level skill to be performed by paramedics only. But in the state of West Virginia, you are actually allowed as EMTs to utilize that King Airway, and that is considered a supraglottic. So supra meaning above the glottis, so we know where the glottic airway is. So it's an above the glottis airway that's to help isolate and control the airway and help manage that patient that can't breathe on their own. When you're assisting a paramedic with their advanced level skills, it's really important to consider the following. One, you have to prepare the patient and have to prepare the environment. So that means that you have to make sure that the equipment is where it needs to be, that the patient is seated where they're supposed to be seated to make it the most simple for the paramedic to be able to function, perform the procedure, and then making sure that there's continuing care and monitoring of those ALS interventions. Some examples of advanced airways. Again, we talk about endotracheal intubation. Now this is, in West Virginia, considered a paramedic level skill. And this is where they actually insert a tube for the patient to breathe through. It travels into the trachea and it isolates the trachea from the stomach content. So it keeps them from aspirating, which is a big fancy medical term for keeps them from vomiting up things that could get into the lungs and create what's referred to as aspiration pneumonia. So they actually, all that gunk in our stomach, all the acids and everything else that's built up, we don't have to worry about. And we want to prepare that patient for the intubation. In order for this to happen, you may be asked as an EMT to pre-oxygenate that patient. That means using specialized equipment that you're allowed to use called a bag valve mask. And you will create a good mask to airway seal, and you will be pre-oxygenating that patient. We're not talking about hyperventilating that patient. We're talking about pre-oxygenating. So we want to make sure we deliver oxygen to help that patient while they're being the actual skill of intubation takes place. And then we move on to the equipment, and we're talking about personal protective equipment. This is, you need to have, for intubation to occur, you need to have your gloves. You should have eye protection and mouth protection as well, because you are right there at the patient's airway. They could vomit on you or aspirate contents, and we want to make sure that we protect ourselves as much as the patient. So we want to also include suctioning, because the patient may aspirate, because they may vomit. We want to provide suctioning and try to keep that stuff from dropping down into the lungs and causing that aspiration pneumonia. There's additional equipment that the paramedic will use that he may ask you to pull. So when you're in that airway bag, you may look for a thing called a laryngoscope handle and blade. They're sometimes referred to as a straight blade or a curved blade. For obvious reasons, one's straight and then the other one's curved like an apple. They are also referred to as a Macintosh blade or a Miller blade. Just remember, Macintosh is an apple and an apple is curved. The Miller blade is the other one, and it's the straight blade. So as long as you remember Macintosh, you'll be good. There are also things called McGill forceps, and these are kind of like pliers, but they reach down in and they can grab objects that get lodged into the airway. And then of course we have the intubation tube, and a lot of times the paramedic will have to use what's referred to as a stylet or a tube introducer. And that stylet actually goes down inside the intubation tube, and it gives it a little bit more rigidity so that they're able to manipulate and make it pliable enough to get into the airway, because it's not a straight shot. Sometimes they have to make a turn. The other thing that may be out there is a water-soluble lubricant. I will be honest, most people have enough saliva and spit that we don't need that. There's a 10 milliliter syringe that is absolutely critical. So always look for that 10 cc or that 10 milliliter syringe. There's going to be a confirmation device as well. And you're going to learn about this later because it's something that you will also use. It's called a colorimetric device or a capnography or an end-tidal CO2 detector. And that end-tidal CO2 detector will have colorimetric paper in it. It's either going to be yellow or purple. And the way to remember this is that Barney, the purple dinosaur, everybody hates Barney. So Barney is bad, and Big Bird, who is yellow, is good. So whenever you pull out that end-tidal capnograph, when you pull that out, that end-tidal CO2 detector, you want to see that as you connect that device to your ventilation tube and you're using that bag valve mask and you're breathing for that patient, over a period of time, you should see that paper turn from purple to yellow. And then there's also some commercially made securing tubes or securing devices to make sure that the ET tube doesn't move. It's also really important, you can help your medic out a lot, if you look at that intubation tube and see what number it sits at the teeth. The typical teeth and tube at 22 is a mnemonic that's used across the board for a lot of paramedics, but it's not an absolute. So you always want to look and see the number on the tube and where it sits in correlation to the teeth. Remember that number, because as you're moving this patient from the floor to the cot from the cot to the truck, when you're moving them out of the truck and into the hospital, and from the hospital to the bed. Each time you move them, that tube gets moved and shifted. And when that happens, you could see a displacement in that number. If that tube gets displaced and that number changes, it's a good indicator to you, as well as the paramedic, to listen for lung sounds and make sure that those lung sounds still exist. And then also, remember those alternate airway devices. The King Airway is one that you can use as a backup if the medic can't get the intubation tube in. So there is a mnemonic device that can be used to help you remember all these steps I've talked about. It's called B Magic. B stands for BVM, so that's the part where we're pre-oxygenating that patient with that bag valve mask. E means that we're evaluating the airway. We want to look for any difficulties with the airway, so we want to make sure that we've got a good seal with the mask, and we want to manipulate that patient to make that positioning the best we can for the paramedic. And one of those things that they talk about is placing crike pressure. So when you place crike pressure, you're finding that Adam's apple and you're pushing down. So if the patient's laying flat, you're going to be pushing down on the Adam's apple. What that does is that takes those vocal cords and it drops them where the paramedic can actually visualize those better when they're looking through the airway. So just kind of keep that in mind. We're trying to manipulate the patient, make sure the head's in the right position. You know, we can use pillows, blankets, and towels to try to drop that head. The best thing is to have that ear in the same line as the vocal cords. So if you can make a straight line, then that's going to help that paramedic be able to see. And we want to attempt the intubation. So that's the A. The GI means that we can also consider using our alternate airways if we need to. That supraglottic airway, that King airway. And then C means to confirm it. When we confirm successful lung placement or tube placement, and your paramedic may ask you this, you're going to listen over the stomach first. If you hear gastric sounds, if you hear air bubbling in the stomach, that means they didn't get in the right place, and that means they need to pull it. Then you're going to listen over the left lung and then over the right. So it is possible that you may have no gastric, and then all of a sudden you listen up here and you have no left lung sounds, but you have sounds on the right. That means that the intubation tube has went straight down and it's bypassed or pushed beyond that left lung, and it's actually going into the right lung. And the medic can fix that. So if you hear nothing on the left, but all lung sounds on the right, you tell the medic that, and he'll be able to back that tube up and get it to where both lungs are being ventilated. So again, we're bag valve mask, we're pre-oxygenating that patient. That's going to be a big job for you. We're going to evaluate the airway for difficulties. It may be that they have this huge beard that's impeding their ability to hold a good face seal. We're going to manipulate that patient. We're going to drop that head into a position that makes it easiest for the paramedic to intubate, and they're going to attempt the intubation. Remember, during the attempt, they may ask you to place what's referred to as crike pressure, and that means you're pushing on the Adam's apple. Then they're going to confirm the intubation. You may be asked to assist with that. Stomach first, then left, then right, and then correct the issues as they're found. Remember, also make a mental note of where that tube sits against the teeth. Remember, teeth and tube at 22 is the typical, but it's not absolute. We're going to continue care with the advanced airways, and we're going to monitor for any change in end-tidal CO2 levels. This is probably something you won't be looking at as much as the paramedic, but you will be looking at that end-tidal CO2 detector that we talked about. Decreasing oxygen sat levels. So you'll actually be able to look at the SpO2 or pulse oximetry and be able to see if there is a drop in the percentage of oxygen that's saturating the bloodstream. And this may seem a little excessive or a little intimidating right now, but trust me, after you get through the airway component of this class, you won't have any issues. You may also note that there's resistance when ventilating. If you note that it started out okay and suddenly you're having trouble pushing that air in, make sure you tell that paramedic that something has changed, because they may have caused a pneumothorax. There could be other issues that have suddenly occurred that weren't there before that the paramedic can care for. So other physical signs of poor ventilation and perfusion include looking for cyanosis. If the skin color isn't fixing itself, if the skin color is still blue or purple, then you still have an issue. And maybe it means that there's an improper placement, or maybe that ET tube, like we talked about, has been dislodged and the paramedic has to make a second attempt or correct what he has. So vascular access is another angle that you may have to assist a paramedic in. And it's a procedure that gains access to the patient's circulatory system in order to either inject or remove fluids, medications, or blood products. The patient preparation part is what you're probably going to be responsible for, and that's where you're positioning the patient and the equipment so that the paramedic can do their skill. So you want to explain the procedure and the reason for it. Usually the paramedic will take care of this and you won't have to. And ensure that the patient is comfortable and calm. Some of the equipment that you're going to see, of course, is your personal protective equipment. If you're just doing IV access, all that is needed is gloves, a proper sized bag or syringe of IV solution. You want to check that medication. You're going to learn how to check medications for the 5 R's or the 5 rights. And you're going to check that IV solution to make sure it's the right one. You want, in most cases, your patient is going to have a normal saline bag of fluid. And they come in different sizes. So make sure you talk with your medic and make sure you're comfortable with your truck so that you're not picking up something that you don't need or maybe that's not appropriate for that particular patient. There's also tubing that's involved, IV tubing, and that's supposed to be a drip set, not a rip set, drop set, if you will. That IV tubing comes in different sizes. There's a micro meaning small. That means that if you pick up the drop tubing, if you look at that drop set, you'll see a chamber. And in that chamber will look like a little teeny tiny needle inside the chamber. The smaller that is, the more micro it becomes. So a micro drip is a 60 drop set, and you'll see it written on the package as a micro drop set. That is really important. Those are specific for medical patients who are usually critical and require medication to be delivered very precisely. The other, and anytime it says 60 drops, that means it takes 60 drops to equal 1 milliliter of medication or fluid. So 1 cc or 1 milliliter. The other common drip set that you'll see is called a macro meaning large. So when we think of a large drop set, we're talking a 10 drop set. That means it takes 10 drops to equal 1 milliliter, which is, while the amount of fluid is the same as the micro, it's how it gets delivered. That's the key. So in the micro, you're going to see that little needle. In the macro drip chamber, you'll see a very large drop coming through and into that. And so you're going to learn how to prepare the skin. You're going to learn what alcohol preps are needed, the adhesive tape and gauze. Usually there is a commercial IV securing system, and they talk about an IV pigtail cath, but that's really not common. And I'm going to try to provide you with some additional videos so you can kind of get a better picture and better visual for what we're talking about. If there's an IV access that's being placed, they're going to want the IV or the venous constricting band, a tourniquet, if you will. and they'll also require an IV cath. These IV caths are color-coded, and that's really important. If they tell you an 18 gauge, it's green. If they tell you something like a 14 or a 16 gauge, you're looking at orange. And the 16 gauges, I think, are gray. But your most common used in the field, if it's a trauma patient, they're going to need a 14 gauge. They're going to need that orange. If it's a medical patient, they're going to need an 18 or a 20 gauge. 18 is green, 20 is pink. If it's an IO access, this means intraosseous. So intra means within, osseous having to do with the bone. So we're actually gaining vascular access by drilling into the patient's bone. And that requires a drill and an insertion, an IO needle. So again, we'll talk about spiking the bag. These are the steps. I'm going to show it to you in a picture because I think it's a lot more appropriate and easier for you to follow if you can actually see it happen. So we'll let this go for right now. We're going to stabilize the patient's limb and provide comfort. And essentially, once that IV is established, your paramedic should be in the back of the truck. You shouldn't have to watch over it. But if you are in a position where you are responsible for that patient, you're watching, you can help the paramedic look for any swelling, bleeding, or discoloration, or something that may tell you that the IV is leaking, that it requires their attention. Now, when it comes to troubleshooting team conflicts, because we're working in a team, we're working as a group, and it's very common to have conflicts among providers from time to time. So just remember there's 5 things to keep in mind. Number 1, the patient always comes first. Try not to engage the other person and keep your cool. Make sure you separate the person from the issue and choose and pick your battles wisely. The big thing to remember in team conflicts is that it's a high stress situation and people often say things or act in a manner that's not normal for them, that may seem aggressive, and it has more to do with the particular situation than anything else. So always try to take a step back approach and choose the battles and make sure you separate the issue. You can always talk about the problem after the call is finished. Make sure you keep that patient as the first priority. This is the end of your presentation for this chapter. If you have any questions, please feel free to reach out to me at any time. If something in this video has confused you, or maybe I went too fast, please go back and check the video. You can always rewatch it as many times as you need. Write down your questions. I'd be more than happy to talk to anybody, and we can spend extra time if we need to. Take care and have a great day.